Before we get started, I have a quick favor. I've been self-funding the Finding Genius podcast for 5 years now. I've done over 3,000 episodes. And as you can see on YouTube, we're up over 1 million views on the channel, which is fantastic. The next thing I really want to push on is to get up to 10,000 subscribers, because once we do, we'll be able to put a donate button, and we'll be able to solicit donations to help keep the podcast running and to also get the Finding Genius Foundation moving along. We have a big project studying anxiety, depression, and PTSD, and working on a product to help people overcome these problems, because I've seen them explode recently after the last 2 years of the whole virus situation. So if you would, please subscribe to the podcast. That would help us tremendously. Give us a thumbs up and check in the description for Buy Me a Coffee. It's about $5. If you could buy me a coffee, I'd really appreciate it. It would help keep the channel going, and I love coffee. Thank you.
Forget frequently asked questions,
common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. My guest today is Nicholas Young, PhD. He's with More Than More's Precision Medicine Solutions, MTM. He's a research scientist and CEO. Today we're going to talk about lupus and perhaps some other autoimmune diseases. So welcome, Nicholas. Thanks for coming.
Thank you for having me, Richard.
Yeah, let's start with your background. How did you get into the investigation of lupus? What did you do before this?
That's a good question. So I did all of my education, the beginning of my training was at Ohio State University. I had an undergrad in microbiology and biochemistry, which, wasn't necessarily lupus focused at all. I ended up doing cancer research in graduate school and really got a lot of training in immunology, and the rest of my career from that point forward leveraged the background in immunology. So I've done work in infectious disease, rheumatology, and oncology with that focus. And the work in lupus specifically was done the Department of Rheumatology and Immunology at Ohio State University Wexner.
Okay. And in the beginning, I know it was important for you to give the caveat that, anything you're going to discuss here on the podcast is more based on your own experience and your own opinion, and it's not necessarily associated with any of the places you worked or work at right now, right?
Yes, that's absolutely correct. I want to have the opportunity to speak freely and at the same time make sure that everybody is aware that I'm expressing my feelings, my opinions, my understanding of the direction field, and not just that.
Okay, well, fair enough. Well, let's talk a bit about lupus. So for the layperson, what is lupus, and what are the symptoms, et cetera, and then we'll dive into it.
So lupus falls under a category of autoimmune diseases. It's rheumatoid arthritis is another common autoimmune. In all of these autoimmune diseases, something happens. There's a dysregulated immune system. The immune system responds to self-targets, reacting to the person's tissue. There's inflammation associated in different targets depending on what the autoimmune disease is. Lupus specifically, you see clinical manifestations primarily in skin, kidney. You get a rash, arthritic type joint. Lupus nephritis is severe pistachios that associate kidney. Again, all of these autoimmunes are something that's dysregulating the system to have it respond to self-target, and really just a very active inflammatory risk depending on the particular autoimmune have different targets. And all of the pharmacological treatments, as you would imagine, are trying to suppress that inflammatory risk. So the research that I did in the field of rheumatology was twofold. Some work we did was more conventional in just trying to understand these inflammatory pathways and then design targeted therapeutics to suppress that inflammatory response. And another part of the research that we did was looking at how complementary alternative strategies such as diet. So we did some work with curcumin, with a bioactive derivative of turmeric, what was formulated in the Department of Pharmacology at Ohio State, and looked at that and suppressing, and then also looked at exercise and exercise's role mediating inflammatory response, and meditative ways. The way that we characterized it was
like how meditation can affect the outcomes of lupus, people that have it.
Yes, so it's psychosocial stress induction is what promotes an inflammatory response. So anything that would be psychologically suppressing that, a meditative type strategy to suppress.
Wait, are you saying that people that have autoimmune conditions, their mood and their emotional state is highly correlative with like a flare-up of their condition? Is that what you're saying?
Well, so what I would say is there aren't studies to demonstrate definitively that there's a direct correlation between those. However, what we do know from a fundamental understanding of the immune system is that you can dramatically affect immune responses with these alternative strategies like psychosocial stress reduction and exercise. So there are and even dietary things. There are ways by which you can suppress the inflammatory response. Is that ultimately to be a standalone therapy for a severe clinical manifestation of lupus? Probably not. But I do think that there is a place for those strategies in conjunction with traditional ecological.
Sure. Okay. Why? I don't know if this is true at all, but autoimmune conditions, they're called autoimmune conditions, but it seems like there's a preferential attack, an autoimmune attack that is limited. It's not like a full-blown response to the whole body is attacking itself. Maybe I'm wrong. But it seems like these different autoimmune conditions, they seem to, the immune system is compromised along a certain vein or in a certain way or for certain organs or certain systems. It doesn't seem to be like a systemic attack. It seems to be more focused. Is that the case?
Yeah, that is. Depending on the autoimmune condition, you'll have more typical organs of manifestations of different specific areas that the immune is attacking, which leads to different symptoms with different autoimmune. Could be inflammation in the muscle tissue, myositis, inflammation, moisture-producing glands of Sjogren's syndrome, so tear gland and salivary gland, lupus, like I said, skin and kidney, rheumatoid arthritis. The list goes on and on. That's a good point. There are conditions by which there can be more comprehensive inflammatory response systemically, but by and large, a lot of these autoimmunes are characterized by more targeted. Really, that's what distinguishes what that specific dysfunction is that leads to.
Yeah, but why would that happen? Why would there be a preferential problem with the immune system, and why wouldn't it just be an overall immune response? Like, what do you think that is?
That's a good question too. So, in the case of lupus specifically, there are a variety of factors that contribute to the development of lupus, and you really can have heterogeneous manifestations of the, had mentioned, target organs, skin. There are patients that don't develop lupus nephritis and have less severe. Why exactly certain organs are targeted and certain organs spared is not as well understood, and is part of what is active research in the field. What is more understood is are the fundamental pathways that are being stimulated different. Sometimes it's similar in the pathway that's stimulated, and it really, over the course of my career, there have been a lot of different therapeutics that have been developed that are targeting these pathways where historically they were giving non-specific, but it's that the steroid, a sledgehammer that shuts down all, and now that more targeted. So I think, to answer your question, you do see an overlap of some of these targeted therapies given from autoimmune condition, but the underlying etiology of why the immune system is attacking certain organs and autoimmune, I think, is less.
All right. So, again, for lupus, how does it start? Is it primarily in men or women? Like, how do people first find out that they have the problem?
Yeah, no, those are all good questions. So, like I had mentioned, it's a heterogeneous disease, so it can manifest differently. And really, I think that that's largely contributed to the fact that it can have a lot of different. So there is a genetic correlation with lupus. However, when they've done studies with identical twins, if it was a 100% genetic association, then if one identical twin has lupus, then the other identical twin should develop lupus, but that's not necessarily the case. It's more like half and half. So there's a genetic correlation. Even seeing 50% is enough to say that there's a strong genetic correlation, but the fact that 50% still don't means that there are other factors at play, which could be environmentally influenced, or different immunological factors, say that it could be stimulated from infection or some other challenge that the immune has where becomes dysregulated from that response. But one of the most interesting and where there is the strongest amount of data is the hormonal end, which you had mentioned as well. And with lupus specifically, what you see is a very, very strong correlation between lupus and physiological levels of estrogen. So when physiological levels of estrogen are the highest, so post-adolescence, premenopausal women, the ratio of female to male patients with lupus is 10-1. When you look at a postmenopausal physiological levels of estrogen drop back down, it's something like 3-2%. It basically goes almost back to 1. So you have a 10-1 ratio that drops significantly down. So there's a strong correlation between estrogen and the lupus patients in general, where it tracks with physiological levels of estrogen. That's always been known. And what a lot of the research that I did, what we tried to do was characterize why that potentially could happen. What influence does estrogen have over the immune system that could contribute to a dysregulation that could manifest? And it was really interesting to me when I first started to examine these questions that when you look across species, so in a variety of different species, humans all the way to much less complex organisms, what you see is females have a longer lifespan than males and are more resistant to infection male. So you say right there's a correlation between estrogen levels and the ability of the immune system to respond to being challenged by an infection.
Before we continue, I've been personally funding the Finding Genius podcast for 4.5 years now, which has led to 2,700 plus interviews of clinicians, researchers, scientists, CEOs, and other amazing people who are working to advance science and improve our lives and our world. Even though this podcast gets 100,000 plus downloads a month, we need your help to reach hundreds of thousands more worldwide. Please visit findinggeniuspodcast.com and click on Support Us. We have 3 levels of membership from $10 to $49 a month, including perks such as the ability to see ahead in our interview calendar and ask questions of upcoming guests, transcripts of podcasts you're interested in, the ability to request specific topics or guests, and more. Visit findinggeniuspodcast.com and click Support Us today. Now back to the show.
What about people that are, they do BHRT, the bioidentical hormone replacement? Let's say they're in menopause or perimenopause. Does lupus?
Yes.
Do they have an instance of it sometimes when they do that?
Yes, you can see higher levels of patients with estrogen.
Oh, that can bring it out?
Patient. Yes.
Okay.
So, so it really, it tracks well with that. And like I was saying, if you say in general, across species, you see more longer lifespans and resistant infectious disease in females, it indicates that estrogen, while it could lead to a heightened immune system, which is great in the defense against infectious disease, it could also allow there to be, a situation where you tip the scales and the immune system becomes dysregulated. And if that happens, then you're at greater risk of developing an autoimmune disease like lupus. So that was really, one of the first areas that I looked into when I really started to examine, just study lupus on a fundamental molecular level, looking at potential pathogenesis of the disease, which if you could identify, then you can really try to develop a therapeutic that's targeting that. What we were able to do was show that if you just took white blood cells, so if I took a collection of white blood cells from healthy male individuals and healthy female individuals and isolated white blood cells, cultured them in a dish in the laboratory, at that point, the white blood cells don't know if they're male or female. They're just white blood cells in a dish. And you expose those, what we did was expose those white blood cells to the antigens that are in the Tdap vaccine, so diphtheria and pertussis. Tetanus. Yes, you're right.
Yep.
Diphtheria, pertussis, and tetanus. So we expose the white blood cells in addition to those antigens. Obviously, there's an immune response that you can measure in growth of the cells because the cells think that there's an active infection. If you do that in combination with estrogen, you get a heightened immune response in both, but that heightened immune response is greater in female cells. So it indicates 2 things. It indicates that estrogen itself can help heighten an immune response, and female white blood cells are wired differently to respond to that estrogen that's in the environment. So it's really suggestive that estrogen plays a large role in the inflammatory response in general. And since it does, it could potentially lead to an area where you're creating a dysregulated immune system and developing an autoimmune like. So
and when you say estrogen, estrone, estriol, which form of estrogen seems to be the predominant cause of problems with lupus, or is it all of them?
Yes. So, I mean, in a physiological environment, they'll be metabolized in a way that they can stimulate the growth of cells. But we use estradiol when we're stimulating the cells in a dish. So that's the bioactive form for white blood cells.
Yeah, but when people do hormone replacement, they may need more estrone, they may need more estriol. It just depends. There's different kinds of estrogen, from what I understand. Is that being studied, or it's just estrogen is being looked at?
To my understanding, maybe in the field of hormone replacement therapy in general, there's a concern for if you're trying to treat a certain condition in that respect. But in the field of lupus and looking at how estrogen is involved in gene regulation, you're assuming that if you're applying estradiol or any form of estrogen, that you're recreating physiologically what's happened with levels of estrogen.
Okay. So what are the different manifestations of lupus? You said one is more kidney focused, one is not. What do the different types of lupus look like symptomologically?
So, like I said, you can really, the most critical, I guess the two most critical distinctions in a lupus patient population be whether the patient has lupus nephritis, so kidney involvement, or neurological related. And so those are the most serious clinical manifestation. Outside of that, the rashes, skin and joint and arthritis.
What age does this tend to onset in women?
Typically, it's older. The younger that you see patients diagnosed, the more severe the condition. So if you do see pediatric lupus, you see less so, but you do see patients in their 20s, early 30s. Those are the ones that usually are the more severe.
Okay, what seems to bring it on?
That's a good question, too. So it's really unknown why disease wasn't there, then all of a sudden was there. What is the impetus to driving that inflammatory response? But estrogen could be something that is involved in that process. What you do see, too, is you can have a patient that receives treatment, goes into a remission, so, very, very, very low disease state, and then has infection that's, unrelated to lupus, just a cold or COVID or whatever it is, and you spark a flare of lupus. So there are a lot of different factors that could lead to either the beginning of the disease happening or a flare of the disease. But at the end of the day, it's really all something that is stimulating the immune system, and that response then goes out of control and becomes pathologic.
Well, again, what is the symptomatology of a lupus flare-up typically?
So again, it would depend on the patient, and really it's inflammation into areas where inflammation has been obviously. So if it is a patient with arthritis, then it would seem a rash.
Why do these old inflammation sites seem to be the preferential sites for the inflammation to recur at? What do you think is left that is signaling the inflammation to begin there again? Or maybe it was never healed in the first place somehow. There's some low-level chronic underlying inflammation that these sites that never leaves but gets activated.
Yeah, no, I think what you said at the end there is exactly what it is. So I always characterize it as embers of a fire, where you're never actually completely extinguishing that fire, but you do have it's a chronic disease. There's chronic inflammation, but even at times where you don't observe clinical disease, you still have that very low level of chronic. Something happens, sparks that, and that's where it will flare. But I think really in a scenario where you always have some low level underlying disease there.
Good. So what are the current treatments for lupus? Like you said, steroids, injections at certain sites. Like what is the protocol?
Yeah, so they do. When I started doing lupus research, this was like 20 years ago, there was one treatment that was approved in the past 50 years, but we're at now 3 treatments specifically approved for lupus in the past 60 years. This, it indicates that we're making progress in the sense that there were 2 new things, but I think it really shows how much room there is for therapeutic development in this area. So a lot of the treatment strategies are that were approved and used for many, many years, like hydroxychloroquine was used since World War II times, and Cellcept, another non-specific inflammatory agent, and steroids have been around for a long time. These new agents are targeted therapies, which are blocking specific signaling pathways within that larger network of signaling of immune system cells. So it indicates that there has been progress that has been made, but again, I think there are a lot of novel targets that still need to be developed. A part of the work that we were doing in research in that area had identified a novel signaling pathway that we did develop an antagonist for, and were able to demonstrate in a mouse model of lupus. So this was a humanized mouse model where we're taking the white blood cells, so the dysfunctional immune system from lupus patients, and engrafting it into an immunodeficient mouse. So you're just using the mouse as a vessel to grow the inflammatory disease in. And we're able to demonstrate that when we did that and used our antagonist, we suppressed the inflammatory response. So it indicates to me that there are a lot of opportunities available for therapeutic development. Unfortunately, I think there isn't that much focus around estrogen and estrogen's driving of inflammation, inflammatory disease, and autoimmune disease like lupus. The pathway that we identified specifically showed that estrogen upregulation, a receptor that's on the surface of certain immune cells, estrogen can upregulate the expression of that receptor, and if you block the ligand, so the molecule that signals through that receptor, that's where we saw that suppression of pathological inflammation in the mice.
With women that are still having their cycle, when does lupus flare-ups happen? Any part of the cycle preferentially? And, what other hormones are present in large amounts at those times that may correlate with what's going on?
It's an interesting question. I'm not sure whether that's been looked at in terms of stages of the menstrual cycle to say at higher levels of estrogen, does that correlate with a greater likelihood of there being a flare in a population of lupus patients? I don't know that, but what I do know is during pregnancy, so say there's a lupus patient that would really all lupus patients in general, if a lupus patient is pregnant, there's a significantly increased risk of recurrence of or flares of lupus or more active disease. So at a time where there's a consistently higher level of estrogen, it may just be a scenario like we were discussing before, where if that cycle is going up and down in 30 days, it might equal a homeostasis of an average level, but 9 months, during pregnancy, very, very elevated levels of estrogen, then there's a definite correlation with exacerbation of disease.
You mean when someone's pregnant, lupus manifests more strongly and more severely? Okay. Interesting. I mean, when someone's treated for lupus, what do they experience? Does it kind of go away and go latent or quiet for a long time?
It depends on the patient. There are times when you could treat to remission and then slowly remove all medication. There are times when you need to be continually treated, but disease is under control. And there are times when you'll have relapse remitting disease or even refractory disease that isn't responsive to different therapies. So all of those scenarios exist. And I think it really just highlights that we need to do a better job subtyping these patients to be able to predict who's going to respond to what treatment and be able to predict the responders from non-responders, or even have a way by which you can use biomarkers to predict disease relapse or disease flare before you actually clinically see a flare. A huge area of research, the second part of what I said with evaluation of biomarkers for prediction of disease flare. One of, in my opinion, the greater deficiencies in the field of rheumatology is the focus on precision medicine and using precision medicine to guide therapeutic decisions. In the clinic, in rheumatology in general, it is more of a scenario where it's a subjective diagnosis of counting number of joints that are flared or whatever, looking at different blood biomarkers and checking 7 out of 12 boxes, and it correlates with a certain diagnosis. So it is somewhat subjective in that sense. And after the diagnosis is completed, they use a recommended treatment strategy. So it's not guided by a specific predictive test that would indicate whether a patient would be a responder or a non-responder. I know, just comparatively speaking, in the field of oncology, that's all that's done. Precision oncology now is taking over that field, and the way by which patients are, nowadays you don't have colon cancer. You have colon cancer that's microsatellite stable, that has a tumor mutational burden at a certain level, that's PD-L1 positive or PD-L1 negative, and all of these things can help determine what therapeutic strategies to use for what patient, even with the same diagnosis. So, two colon cancer patients don't get the same treatment because of that molecular profiling that's done at the beginning to determine what the treatment strategy should be. In the field of rheumatology, you don't see that yet. And I say yet because there recently was one test in rheumatoid arthritis that was just clinically approved where they're able to distinguish population of patients that would be responders from non-responders based on a panel of biomarkers that they get from doing a blood sample. So just looking at white blood cell levels of expression of different genes. And I think that's really where rheumatology needs to go as a field in terms of being able to characterize these patients better at diagnosis to be able to determine which treatments to use, because you really are just cycling through different treatments and seeing what works and what doesn't work.
Yeah. Okay. Are there any unusual manifestations of lupus in certain populations, in men or in, younger people, or again, the nephritis heavy type of lupus?
So you do see greater predisposition to lupus in certain populations of patients. So females, obviously, like I had said, but Asians and African Americans too, there's a higher incidence of lupus. Why that is also unknown at this time to say what genetic background. Are there certain genes that are involved in making different populations of patients, different populations of people more susceptible to developing disease?
Other autoimmune conditions that tend to accompany lupus when it manifests?
A lot of the times you'll get this blanket diagnosis, and if you have joint involvement, it could be rheumatoid arthritis technically, but it still falls under the umbrella of it being lupus. So I think there are different autoimmune conditions that could go along with a lupus diagnosis, but it all also can fall under the greater umbrella of a lupus diagnosis anyway. One thing that I wanted to talk about too, we had talked about the pharmacological treatment strategies and what to do. I wanted also to talk a little bit about the research that we did with exercise and psychological stress reduction. I think that part of the work that I did going into it, I have a background in drug design and development. I was less excited about this work. In the outcome of this work, it really, really demonstrated to me how these non-pharmacological interventions could significantly impact the pathology of the disease. So we started all of this work. We had a lupus mouse model, and in our lupus mouse model, we had 3 different arms of the study. So these mice, just because of genetic predisposition, naturally develop lupus nephritis. So you could see in the kidneys the inflammation that develops in the kidneys, and you see it. It's called blood urea nitrogen levels in their urine. So you're able to track disease just through levels of these markers in the urine. And then when you look at the kidneys themselves, you see inflammation. So what we did was take that mouse model. We either did nothing, and that was our control, or we exercised the mice. And we exercised the mice, not rigorous exercise, but mice on a treadmill. We had to train the mice to be able to walk on the treadmill and, follow our directions. So they would do treadmill walking. That was the equivalent of a fast walk, of a human fast walk, not sprinting, not even jogging, just a fast walk for 45 minutes every day, 7 days a week. And the other group of mice was exposed to a protocol that was